Hi guys, can people hear me?
Yes.
I can hear you.
Perfect. All right, well, I'm a little early, so we'll just let other people join in. Glad to have all of you here today.
Hi, Valerie.
Hi, Zach. How you doing?
Good, good.
Just while we're making conversation, has anyone had any COVID-19 babies in their NICU?
We don't have any COVID positive babies, but we have a lot of COVID positive moms. Just that very sick, 25 weeks mom who had been intubated has gotten through all the treatments, including plasma, the serum, and the baby got delivered. And baby's nasopharyngeal and oral swabs have been negative.
Oh, wow.
But we sent a tracheal aspirate because I don't know what the sensitivity is or specificity of these tests are. So we sent a tracheal aspirate request. So we're waiting for that. We should know the results today.
Oh, so interesting.
Yeah.
Hey, Anup, how are you? I see you just joined.
Hi guys, it's Jonathan.
Hi, Jonathan. How are you?
Good. How's everybody doing?
I think we're all hanging in there considering.
Yeah. Our hospital has been in an absolute frenzy over the last couple of weeks. We've had, I think today we're sending our 1,000th test as a hospital.
Oh, wow.
We've been hit very hard.
In the NICU as well, or all mostly the adult side?
Seems like just like everywhere else. Our NICU cases are minimal. We've had 0 affected babies, but a lot of affected mothers. And so, based on their symptomatic profile, we've had to kind of decide what to do. But for the most part, it's either you separate them or you don't. So if it's a binary decision like that, usually you can figure out which is the easiest path to take.
Yeah. While we're waiting for more people to join, Anup, are you able to share your screen? Just want to see if that's going to be working out okay. And I can't hear you either, so you may need to unmute yourself.
Sorry about that. Okay.
Great.
I'm unmuted. Now, I just got to figure out the right screen. Let me pull this over here. Screen 2. Let's see if that works. Can you see that?
Yes,
Okay.
Perfect.
All right.
Let me just wait a little bit longer. I think there were about 25 people that RSVP'd they were going to call in. So
Great.
Yeah, exciting.
Hi, Anup. How are you? Ram here.
Oh, hey, Ram, how are you? Doing okay. You guys okay over there in LA?
Yeah, you're okay.
Good, good.
Just beginning to see pediatric patients.
Oh, you are? You guys, they've re-triaged you guys to doing peds?
No. In the PEDS floor, we have 3 COVID positive pediatric patients.
Ah, got it, okay.
Yeah, but luckily, none of them needed intubation or anything.
Yeah, no, that's good. Yeah, we only have babies, but we don't have anybody, no moms have been positive, so.
Oh, no, that's good.
So we haven't done universal testing, you know, like that thread that people are looking at for screening moms, but they've been talking about it. But I know you said you tested 70 and got all negatives, right? So
Cedars did that, not us. Yeah.
Oh.
So then they start the routine testing. But we are pushing for routine testing. Yeah.
Yeah, so are we. Yeah.
All right, you guys. Well, it's a little after noon my time, so maybe we can get started as people begin to join. So welcome everyone to our second ever Neonatal NIRS Consortium webinar. We're really grateful to our speakers today, Anup Katheria and Rhee, for talking about NIRS monitoring in the context of intraventricular hemorrhage. Just as a reminder, we're going to have the 2 speakers talk first, and then we'll have some time at the end for questions. If you want to, you can also use the chat box to enter your questions for later reference. In the meantime, please make sure if you're just joining in that your phone or computer is muted. And then just thank you again to everyone. I know in this crazy time to take the time out from your clinical responsibilities to do a little learning about NIRS. So with that, I want to introduce our first speaker, Anup Katheria, who is from Sharp Mary Birch in San Diego. He's done some amazing work. I think a lot of the work with umbilical cord milking versus delayed cord clamping, but also with NIRS monitoring starting in the delivery room. So I'm really excited to hear about what you have to say. Take it away, Anup.
Great, thanks so much and for the opportunity to present. And yeah, you know, for the sort of sake of time and balancing what Chris will be talking about, I'll mostly pretty much entirely focus this talk on NIRS use in the delivery room. There's obviously plenty of research in NIRS overall, but I think we'll sort of hone in on what's out there. And obviously I have no disclosures, and some of the stuff I'll be presenting were for some of our grants. And so, you know, to focus a little bit on when we think about, you know, just monitoring and obviously why we monitor is to really, for our preterm babies, we're interested mostly in preventing and looking at brain injury. And, you know, in the delivery room, we only really have these 2 variables, right? We have heart rate and pulse oximetry. And you know, they're great for resuscitating babies, but they don't really give us an idea of, you know, brain oxygenation in the delivery room. We're really looking at systemic oxygenation when we use a pulse ox or even for ECG for heart rate monitoring. And, you know, overall there on the right sort of has some of the, you know, basis for NIRS and what we're looking at, but we've already heard that on prior talks. But we know that NIRS is really good for continuous non-invasive monitoring. We can use it in very sick patients because of how non-invasive it is. And we know that it works. Like, you can detect early brain injury, and it can be much faster than looking at things such as blood pressure, lactate, or urine output. So we know that earlier detection of it might be useful. And so why would you take all that time and energy that move it all the way into the dull room? Most of us don't have NIRS technology in our delivery rooms. We may have some of them in the NICU, but there is probably a rationale for that, which is that we know that monitoring preterm babies during resuscitation, there's a lot of changes in hemodynamics and blood flow and physiological changes going from fetal oxygenation to then neonatal newborn oxygenation. And in that sort of window of these changes, there may be an opportunity to correct some of the abnormal physiology that's going on in a baby that might have poor perfusion, poor oxygenation that we may be able to detect sooner. And what's always dramatic is when you sort of go from the delivery room to the NICU, you're talking about a span of in 15 to 30 minutes. All of a sudden, your monitoring becomes far more extensive in what we do in the NICU. You know, we're monitoring continuous blood pressure, heart rate, even with our ventilators, we're monitoring continuous tidal volumes, et cetera. So the idea that all of a sudden the DR becomes this place where we're doing minimal monitoring and then all of a sudden expands within a span of 15 to 30 minutes sort of seems odd. And I think the part of that is, can we move some of that into the delivery room to get a better idea of what's going on in the newborn? So, to sort of illustrate how you can do this, this is our setup at Sharp. We're a community hospital, so we sort of have to go in with a throw of things. And at our center, we're the busiest delivery hospital in California. We have the most deliveries, so we constantly are moving babies in and out of our delivery room. And this is the setup. It's just a regular Panda bed, but then we have these additional monitors sort of on shelves and, a little tablet that people can look at things like, pressure waveforms and what one of our studies that we'll be talking about, even EEG and FiO2 tracing. So it's doable. It's not something that, has to involve fancy equipment. These are all standard things that, you could sort of go buy and stick in your delivery room if you needed to. So that was more for just illustrative purposes. Okay, so getting into some of the research, there's not, you're going to hear from Chris a lot of the studies that are going on in the NICU period when the babies are there, looking at continuous monitoring for hours. But as far as focusing just in the delivery room, there are a few studies that have been developed. Most of these actually come from Europe. And the first slide I have up here by this group by Gerhard Pickler has done a lot of great work in Austria, as well as some of his collaborators, and really defining sort of what are our norms and sort of how these curves look, similar to what we do with pulse oximetry. And so this first set of data, they included a good sample size. It's over 380 babies, but it was sort of a mix. 80 of them were term babies that had vaginal delivery, 200 were C-section babies, and only 27 of these were actual preterm babies under 32 weeks. But with that larger sample size, you could sort of see these normative curves. Obviously, these numbers start out much lower than what we see with pulse oximetry, but it gives you an idea of sort of what's the 10th percentile that's shown down here. Oh, sorry, my pointer probably doesn't work, but and then obviously that lower line and that top line showing you the 90th percentile. And then there's a study that came out of Cork by Gene Dempsey's group that looked at babies who actually ended up needing more oxygen. So in Cork, their standard is starting at babies off, initially usually around 30%, but some, depending on provider and how sick the baby was, they may have gone up. And what this sort of shows is, it's a little bit difficult to understand, but there's no FiO2 data. This is solely the NIRS. But the babies who ended up needing more than 30% oxygen, that is, they had to go way up, are the babies in that sort of red line. And the black line are the babies who, the entire resuscitation, they needed 30% or less. And what it sort of showed is that the babies who ended up being more hypoxic actually started off with a much lower NIRS. Despite them trying to give them more oxygen, their NIRS was low up until around 7 or 8 minutes of life, sort of illustrating that there's sort of this cerebral hypoxic period in these babies who are actually sick, despite you trying to give them more oxygen. And so that's sort of the early data that maybe NIRS might sort of illustrate early changes. And then there's this other study that combined NIRS and EEG. Now, I know this is not an EEG talk, but a lot of people have also looked at, well, if you really want to look at brain injury and brain activity, EEG sort of is the gold standard, and can it be used during resuscitation? So they combined both AEG and NIRS in this study, and on the left panel is your NIRS data, and they looked at babies over 34 weeks. So these aren't extremely sick babies, but they looked at babies who needed respiratory support, comparing to the babies who needed nothing. And you can see on this sort of top left panel, the babies who needed no support actually had higher NIRS sort of throughout the first 10 minutes, compared to babies who needed some resuscitation, clearly had lower NIRS in that first 7 or 8 minutes of life. And then similarly with EEG, when they looked at the first few minutes, really up to 3 to 4 minutes of life, there was a sort of difference in their mean voltage max signal when they were looking at their AEG signal, showing that there's a difference there as well that was being able to be picked up. And I'll just show these 2 slides here to give you an idea of sort of the challenges with EEG. I got these slides from actually from Cork, that does a lot of EEG monitoring in the delivery room. And you can see here this video, I don't know if it'll play with the streaming, but you can see the challenge of using EEGs for babies. This is in a 34-weeker, but if you were using it in smaller babies, like at 24, 25 weeks, doing this sort of could be quite tedious during resuscitation. So I think the idea of EEG is really novel and useful. Obviously, we use it in our NICU for HIE infants, And this is probably being adapted and streamlined. I know people that are using mesh hats, et cetera. But it is something else that's out there when we're looking at neural monitoring in the delivery room. The other study that has been out there for quite some time is by the group in Ulm, by Helmut Humler's group, and this is a paper by Fuchs as the first author. This was looking at preterm infants. These were all under 32 weeks of age. And again, defining a little bit better the idea of these normative curves. Now, this was only using about 500 babies and a mean age of around 27 weeks. But you can see these numbers are lower. They compare the babies that needed no respiratory support here in black to the light gray, which is the babies that needed some form of positive pressure or a sustained inflation that they use oftentimes in Europe. But looking at these babies who were sicker, there was really not a big difference, but more importantly, they were able to sort of identify what a normative curve would look like for a smaller gestational group, not so much of that wide range that we saw with the Pickler data. And then they had 2 babies with IVH, and this sort of gets into some of the research we're interested in, which is identifying babies that could have IVH early in the Dell room. And these 2 infants, one with a grade 4 and one with a grade 2, you can see here that they were below this sort of 10th percentile curve. Obviously, the baby with grade 4 IVH really never ended up achieving a normal cerebral saturation. So again, giving you a clue in that maybe these babies who have IVH can actually be detected even as early as the Dell room. And then another this wasn't a randomized controlled trial, but what the same group, Pickler's group in Austria, looked at babies with IVH compared to a sort of age-matched control, because they do lots of NIRS monitoring in the Dell room. So there were only 12 babies in each group, but when they looked at their non-IVH sort of retrospectively matched control group here, and you can see the differences or the lack of differences between the 2 groups in terms of age and APGAR scores, et cetera, that really the babies who had IVH ended up having a NIRS that never really got to normal. And I think that's one of the sort of signal or themes that we're seeing a lot with NIRS research in the Dell room, that both groups start off sort of similarly, but that IVH group sort of continues to stay lower and never quite gets to that normative range that you see in the babies who don't have IVH. And they started seeing a signal difference sort of after 7 minutes of life. So again, small numbers, but sort of following a trend. And then I'll talk about, for the next few slides, our study we did here in San Diego. Again, we were trying to mimic what they were doing in Austria, looking at NIRS and EEG. That was sort of the premise of this early study. And it was basically a prospective cohort study of 120 kids looking at EEG and NIRS to see whether or not we could predict IVH. And this was our setup. It was very simple, and crude, and I'll show you a little video some of you may have seen before as well. But basically, the baby's head goes right on top of this X, and then you just sort of wrap it around the forehead, and then you have a ground EEG lead here, and then basically it's 3 total leads that are on the baby. So it's a very limited montage and that we sort of tried to do with our neurologists here. And then here's a little video. I'll sort of show, I don't know how well this projects over for you guys, but in the bottom left is your is the EEG, and on the bottom right is your NIRS. The baby has nothing placed on them right now, but is getting some resuscitation. And then in about 30 seconds, you could see as the band comes on, one of the things I really like about NIRS is that it's instantaneous, right? Unlike pulse oximetry that takes anywhere from 60 to 90 seconds to get a signal, your NIRS is very fast and you get data right away. So this just shows you how we were trying to use it during resuscitation, and it can be done. And contrasting that with that picture that you saw with the multiple EEG leads being placed on the infant. So there goes the lead right there on the forehead, and it's covered, and almost instantly you start seeing some EEG signal on the bottom left, and on the bottom right, the NIRS value sort of pops up there. So that's just to give you an overview. And then in our study, you can see here that we didn't have very many babies with IVH or death, but you were able to see the normative things that you would expect in sicker babies. They were more preterm, smaller weights, actually few of them were delivered by cesarean section. There was a higher incidence of chorioamnionitis, and they had a lower 1-minute APGAR score. So clearly these babies were sicker at birth, but obviously we wouldn't know which ones developed IVH or not. And when we looked at just the delivery room alone, and these are measures that we collect on all of these babies at birth, The dotted line are the babies that developed IVH. The solid line are the babies who did not. And so normal parameters that we would look at, like heart rate and SpO2, there was no difference. But when we looked at StO2, which is, we use the foresight NIRS, and that's the parameter we collect, you can see at 7 minutes and after there was a difference, again, that the babies that had severe IVH did not sort of move up the curve as you would normally expect with the healthier kids. No difference in AEG, no difference in FiO2 or mean airway pressure, although you can see that the babies who were sicker or had severe IVH tended to need more oxygen and more ventilation. And when you blow up that same curve for the StO2 and plot it here, and this is a little bit easier to see, you can sort of see this sort of swing in data, but more importantly, that the numbers don't really get elevated to that red line. And when you sort of do an area under the curve and looking at 7 minutes with an StO2 of 66, babies who had a NIRS stat of 66 or greater did not develop IVH or severe IVH, and it was pretty highly sensitive and specific with a p-value of less than 0.001. So it's sort of the first kind of marker of wellness when you're looking at these preterm babies, to look at babies who are at high risk for developing IVH or not. But, you know, again, these are small numbers of having only 12 kids that had IVH or death in this cohort. And we did also compare that to other risk factors for IVH, like gestational age and choreo, that were positive in, or statistically different in the two groups. But you can see here that the NIRS value still has, in the final regression model, still being highly significant for predicting IVH. And then sort of moving on into next stages, the group in Austria continues to sort of move ahead, now looking at NIRS as an intervention, at whether you have the availability of a NIRS value or not, and looking at sort of guiding oxygen treatment. So their first sort of pilot study that they looked at for feasibility, again, this dotted line here was the 10th percentile for their NIRS based on their original studies. And they looked at whether, when they had the NIRS visible or not visible, to look at differences in sort of oxygen-guided treatment. And I'll get into that more when we talk about the ongoing trial that they have. But when they looked at babies that had a NIRS visible versus not visible, again, no major differences, but there were just some trends here, such as things that they were looking at, like BPD, ROP, and some of those things that actually look a little bit higher, so maybe suggestive of more oxygen use. But they didn't see any differences in the outcomes that they're looking at now, which is things like IVH or severe IVH. So that's something that they're continuing to follow. Their primary outcome, which is what they're going to be looking at for the main trial, though, actually looked reduced in the babies with NIRS visible, that there was less mortality or cerebral injury when they combined those two. So this was their sort of first attempt at seeing whether or not this was feasible. Now getting into where they're at currently, and sort of maybe where the future of this is going with NIRS monitoring, is randomizing sort of a larger cohort of babies to having the NIRS available or not, and does this actually reduce brain injury or even death in the NICU? And so this is the CAUSE-GOD3 trial, and I have the title up there in the mnemonic. And currently, there are no US centers, to my knowledge, participating in the CAUSE-GOD3 trial, though there are some Canadian centers in Europe that are mostly been doing this. And this is the parameters they're using for the study. Again, the protocol is available online, and that red dot is what they're, and the red line is what they're focusing on, which is to stay above the 10th percentile in terms of titrating your oxygen levels. And the way they're doing that is they're sort of first focusing on, normal NRP steps, the baby's breathing, and then and ventilating, and you sort of target your SpO2 like you normally would. And then if the baby is within SpO2 parameters, then you're sort of fine. So the control group is really just focusing on normal NRP steps per se. And then, they're looking at ventilating and increasing the FiO2 if the baby's having low sats, et cetera, what you would expect. And you follow that every 60 seconds. The difference is in the intervention group, now that you have the NIRS visible, is that you have the second step. Once the baby is within SpO2 target ranges, you now look at the NIRS on top of that to see if the baby is staying above or less than the 10th percentile. And if they're then less than the 10th percentile, you can do things like increasing your ventilation, or actually going up on your FiO2 or considering fluids, et cetera. So it's adding another level. You still focus on SpO2 as your primary monitor, but then you add the StO2 or the NIRS values once you're within target ranges. So that's sort of a summary of that trial that's been ongoing now for a couple of years. And then lastly, I know I have a minute or two here to talk about future directions. The other group that I'm also interested in is that the term HIE infant. And I think one of the things that would be really fascinating is to look at whether or not NIRS could have value in that population. And we know, again, NIRS is used, we have people on this call like Chris, et cetera, that have looked at NIRS and Valerie in the NICU looking at HIE babies and to help prognosticate long-term outcomes. And the thing that's always interesting with NIRS, it's sort of different, right? In the HIE population, that it's cerebral hyperoxygenation with babies, and it's thought to be due to this low energy metabolism after severe injury with low oxygen utilization, cerebral hyperperfusion, and obviously poor autoregulation. And most of you have seen this data, but just for the sake of where we're thinking is, this is an old paper by Judith Meek, and they looked at cerebral blood volumes, and this is a little bit beyond my total understanding, but it's really looking at when you sort of adjust the FiO2, sort of see this change in signal, and based on that and combining with the hemoglobin, you can essentially calculate a cerebral blood volume, and you can see here that the babies that had more brain injury had these larger cerebral blood volume increases compared to the babies who were with minimal injury, or as you're looking over here, babies who died or impaired, that number sort of goes down if you're normal. So there's good data in the NICU. I'm still interested whether or not this could be something that we could do in the DEL room. While I haven't head-on looked at this, we are sort of indirectly looking at this in one of our trials that I'll get to in a second. This is some more data in the NICU as well, looking at cerebral oxygenation and brain activity after asphyxia, showing you again that the dotted line are the babies with injury that have these higher NIRS values compared to the babies who are normal. Actually, the NIRS values don't quite get as high, so showing they're not getting that hyperoxygenation state. And this was looking at babies all the way out to 18 months. So obviously has some prognostication there. So this is our study. One of the things that I think Valerie mentioned earlier is we obviously look at cord management. It's been a long-term interest of mine, and we're looking at non-vigorous infants, of which many of them, come out quite depressed. And they're randomized in this study to early cord clamping and cord milking, but we're putting NIRS on them for the first 10 minutes of life. And the question is, are these values different when you milk versus when you're just clamping early? But I'm also interested on whether or not some of these babies that develop HIE and that we follow them out to 2 years, was there any prognosticative value in looking at that? And one of the things I'm still intrigued is if we could design this sort of study, looking at these really sick babies that get NIRS right away. To me, it's sort of this early tool. You could start, hypothermia right in the DR, turn off the warmer and know that baby's coming down even before the cord gases are there, or even use it as a tool in conjunction with your neuro exam to say, well, clearly this baby has suffered an injury because we have some value. So looking at that sort of cutoff value. So anyway, that's something that's just a side note, but something that would be another use for NIRS in the DEL room. So to wrap things up, really NIRS is, as we all know in this group, it's a useful non-invasive measure for looking at oxygenation as well as perfusion. And again, while we have some, there are some variation on normative values, again, depending on what device we use, I think the trend monitoring is really important. And I think studies like the COD-SCOT-3 really help us about using it in the DR. If they can show a reduction in brain injury, I think without question, we should be looking at using it in the DEL room. And then, if we find some data in our MinV trial with HIE patients and maybe others start looking at that, that could be another tool for us to use as well in that population. So with that, I'm obviously grateful for our study team that helps us do this research as well as our funders. And sorry, I know I went a couple of minutes over, but thank you.
That's fantastic. Super interesting. I know we all have a lot of questions, but in the interest of time, maybe we can hold those questions for the end, or like I said, put it in the chat box and we can get to it at the end. And you might have to stop sharing and allow Chris to share his screen. And so while Chris is setting up, many of you are really aware of Chris Rhee is one of our neonatologists at Texas Children's Hospital. He's done a lot of amazing work with NIRS monitoring and autoregulation. So I'm very excited to hear about what he has to say. And then just to take the one brief second on behalf of myself, Jonathan Mincer, and Zach Vasilis, we've been trying to put together these quarterly NIRS Consortium talks, and I hope they've been helpful to all of you so far. We're really eliciting, it's such a rich group of people here that are interested in advancing NIRS monitoring, and we're hoping we can call on many of you in the future to contribute to this ongoing exchange of ideas. Okay, Chris, it looks like you're ready. Take it away.
All right, thanks, Valerie. Can everybody hear me?
Yep, we can hear you.
Okay, great. Well, thanks, Valerie, Zach, and Jonathan for the invitation to talk about NIRS and IVH prediction. Well, we know that IVH and severe IVH tends to continue to be an issue for our most premature infants. As Barbara Stoll has reported in the trends of severe IVH from 93 to 2012, there's been a relatively plateauing of IVH that has occurred as we advance in increasing gestational age. But with increased resuscitation of smaller infants, we still do see a fair proportion of severe IVH that is occurring. I thought this was an interesting study that came out of Japan within the last kind of year and a half, and they just looked at the neurodevelopmental outcomes of infants less than 500 grams. Obviously, they resuscitate many within that weight category. And they looked at what the neurodevelopmental outcomes of that group was at 36 to 42 months. And overall, the neurodevelopmental impairment proportion was around 60%. But what they showed was that severe IVH and cystic PVL still have an increased absolute relative risk of around 1.4 as they are associated with neurodevelopmental impairment. So there's still a lot of importance in studying how to prevent IVH. Now we know that the brain is at risk for both hypo and hyperperfusion injuries, and most of our treatment guidelines promote increasing blood pressure to improve brain perfusion. And there are multiple theories on the pathogenesis of IVH, with some of the most common pathways being fluctuations in arterial blood pressure, which can overwhelm the fragile germinal matrix, while the other most common theory is obstruction of the venous system through various mechanisms related to pneumothorax or asynchrony with the ventilator, all leading to rupture of this fragile capillary bed. And in addition, it may be that there are both repetitive cycles of ischemia and hyperperfusion and reperfusion, which further put the brain at risk. This is also the group from Cork that looked at the cerebral oximetry over the first 48 hours of life, comparing extremely preterm infants here, let's see here, in the kind of lighter blue, who had a gestational age of less than 28 weeks, compared to very preterm infants who were 28 to 32 weeks gestation. On the y-axis is the mean cerebral oximetry data, and the data is displayed here in 2-hour epochs of time with postnatal age on the x-axis. We can see from this graph that in the extremely preterm population, they have relatively lower cerebral oximetry values compared to preterm infants. Now, Nurig and colleagues reported patterns of cerebral blood flow in a small single center cohort of 22 patients, with those who had IVH and those who didn't. They also measured cardiac function, and cerebral blood flow remained relatively stable in the very preterm infants who did not develop IVH during the first 3 days of postnatal life. However, in the very preterm neonates developing IVH in this period, they did note lower systemic perfusion and cerebral blood flow, followed by an increase in variables preceding the development of IVH. The graph on the left here is the Bosk-Whisker plots of the oxygen extraction values over the first 12 hours of the study. Here we can see that the IVH group had a much higher oxygen extraction when compared to the no IVH group. On the right, we see changes in cerebral RSO2 and oxygen extraction in the two groups, with the RSO2 on top and the oxygen extraction on the bottom. The no IVH group exhibited stable RSO2 and oxygen extraction over the first 72 hours of life. And in comparison, we see that the group that did have IVH had an initial increase in RSO2 followed by a decrease over the time frame. The shaded out area here shows the timing around when the IVH occurred. In a slightly larger single center study of 43 infants by Sortica da Costa from the UK, they looked at changes in cardiac output and cerebral oximetry over the first 48 hours of life. And those patients with IVH here on these slides with the dotted line and no IVH who were the solid line. They showed that both the left ventricular output and the right ventricular output, A and B here, increased over that 48-hour period. But the mean tissue oxygenation index or oximetry number had no significant increase in either the no IVH group or the IVH group. When they looked at the mean tissue oxygen extraction factor, there was a significant increase in the no IVH group, but no significant increase in the IVH group. In addition, this group did measure markers of cerebral vascular reactivity as a function of the correlation between oximetry and cardiac output, and observed a positive correlation between the oxygenation by NIRS and the cardiac output at around 24 hours of life. And in those infants who developed IVH, this might have been suggestive of cerebral blood flow becoming passive to systemic blood flow in those who developed the IVH, because this is about the time when most of the infants develop the injury and may suggest the hypoperfusion-reperfusion injury. Now, the Dutch group, Anderlecht and al., used a case control study to sub-analyze 30 neonates who developed IVH after 12 hours of life. And this was part of a larger perspective observational cohort study. In this study, we can see that on the graph on the left is the mean RSO2 in the pre-IVH state and the post-IVH state on the right. For each group, they have general groups of IVH, in the middle, low-grade IVH, and on the end, severe IVH, and compared them to controls. What we can see here is that the RSO2 for the infants was significantly higher in those babies who went on to develop IVH before the IVH had occurred. Further, when they calculated the correlation of blood pressure to cerebral oximetry to identify relative states of autoregulation, correlation indicated that more blood pressure passive perfusion in infants occurred in those who had IVH. I think from this study, it's possible to see that continuous assessments of patterns of cerebral oxygenation and arterial blood pressure may aid in identifying those infants at risk and prompt consideration of preventative measures. Now, I know a lot of this group is knowledgeable about cerebral autoregulation, so I'll keep some of this brief. But we know that oftentimes in premature infants, cerebral autoregulation is impaired. And multiple groups have shown that the impairment decreases, or there is more impairment of autoregulation with decreasing gestational age and birth weight. The Boston group has elegantly showed that when they were able to compare infants who had impaired versus intact autoregulation, over 40% of those with impaired autoregulation developed some type of premature brain injury compared to 13% who didn't. Now, I really like this autoregulation curve from Volpe's 6th edition text, where we look at the comparison of autoregulation between preterm, term, and adult patients. It's clear that the autoregulatory plateau narrows with the lower gestational age, adult being from 60 up to 150, term infants from 30 to 50, and preterm infants is pretty low. And in addition, I think what is important is the normal preterm blood pressure rests probably around that plateau or around the lower limit of autoregulation. Now, we have looked at autoregulation across the cardiac cycle using transcranial Doppler ultrasound, obviously not the focus of this talk, but I just wanted to demonstrate when we looked at how autoregulation was measured as correlations of systolic blood pressure to systolic flow velocity, that we saw a positive number here indicating impaired autoregulation and a 0 or negative number indicating intact autoregulation, that across advancing gestational age, we saw that systolic blood flow was more regulated with advancing gestational age. We also did note that mean and diastole did not show very much regulation of cerebral blood flow. However, there's NIRS data to support this change in autoregulation with advancing gestational age too. And this really nice study by Zach and his colleagues in St. Louis using transfer function analysis, they demonstrated that the evidence for dampening of spontaneous oscillations in systemic blood pressure by the cerebral autoregulatory system were prominent right around this 0.1 frequency that is synonymous with the Meyer wave frequency. Furthermore, the graph on the left nicely shows moving from a lower gestational age of 24 weeks in red to blue at 28 weeks, that the dampening ability increased as a function of advancing gestational age at birth, which promotes this development of autoregulation that occurs as our infants get older. On comparison, on the right graph shows the dampening between infants with IVH, who are the solid line, and those with no IVH, the dotted line. And here it shows that in those infants who developed IVH, they had a statistically worse ability to dampen their systolic blood flow fluctuations, even when holding other clinical factors constant. Others have used autoregulation indices, here the COX, or the correlation of cerebral oximetry and arterial blood pressure, across various preterm infants, here all less than 30 weeks of gestation. The graph here shows the autoregulation index on the y-axis and blood pressure on the x-axis, with a dotted line denoting impaired and intact autoregulation. And here we can see as blood pressure was lowered, impaired autoregulation occurred more frequently. And as a percentage of time, we can see that infants spent a lot of time at blood pressures where their brain could potentially be at risk for impaired autoregulation. Flora Wong and her group in Australia have also shown that in clinically stable infants, high blood pressure variability occurs when autoregulation is impaired, and in sick infants, impaired autoregulation may occur with low arterial blood pressure variability. So the question becomes, can autoregulation metrics help to define neonatal optimal blood pressure? This is just a sample recording of slow waves of blood pressure and blood volume measured by NIRS And when continuous correlation coefficients of these measurements are made, we can determine a state of intact autoregulation and impaired autoregulation when the data is of NIRS cerebral blood volume is plotted as a function of blood pressure. And when taking into these data, we can bin it by degrees of blood pressure to see where the best blood pressure for the brain perfusion of a given patient is. Now, we were able to monitor a patient who developed IVH on day 2 of life progressively, looking at impairment of autoregulation across that same time frame. And what we saw in this infant was that the highest degree or highest percentage of time with impaired autoregulation coincided with the time when the injury occurred, but the autoregulation improved following the injury itself. The group in Cambridge has also looked at other ways to identify the optimal blood pressure and discovered that heart rate has an important role in cerebral oxygenation as well. In this study by Mitra and colleagues, they looked at 31 preterm infants and used a correlation of cerebral oximetry to heart rate, the TOHRX, here on the y-axis. And what we can see here on the top graph, that as the subjects became more desaturated, autoregulation was more impaired, and that for the cohort of patients, when they plotted what the autoregulation indice was at the blood pressure, we start to see this kind of viewed out shape to the data, identifying a time or identifying a blood pressure at which the brain was most happy. Now, they followed up this study with a larger study using this TOHRX to identify optimal blood pressure in these infants based on NIRS data, and showed that when there was a greater deviation below the determined optimal blood pressure, this was associated with both increased rates of IVH and death in this cohort. And this graph shows just what that optimal blood pressure looked like on the y-axis across the various gestational ages. And as we can see, there is a lot of variance even for one gestational age where that definitive optimal blood pressure was for this group of infants. So I think when we think about autoregulation and oximetry, we have to potentially rethink about how we're looking at autoregulation. Well, we know there's a plateau where blood flow is optimal for prevention of brain injury. The reality is most of our infants live somewhere in between this lower limit of autoregulation and the critical closing pressure or the theoretical zero flow pressure of the brain. And I have done a lot of work in that area, but I think with the focus being on NIRS work, we're still trying to derive ways to connect the NIRS data with some of the Doppler data that we've collected. In closing, I think it's important that we note that measurements of cerebral oximetry have been associated with poor neurodevelopment. This is a follow-up study from the Dutch group that looked at cognitive outcomes at both 15 and 24 months corrected age. And as we can see, when either the RSO2 was less than 55% or greater than 1.5 standard deviations, we can see that there was a 2.5 increase odds of developing IVH at 24 months corrected age. And even at 15 months, they saw a 3.2 increased odds of developing IVH. So I think there is merit in monitoring the patterns of oxygenation, and perhaps we need more data on how this behaves, not just within the first 72 hours, but over longer periods of time. And finally, while I didn't touch a lot on the Safe Boost trial, this was some of the data that was reported on the relative rates of IVH in that study. And as you can see here, there was an increased risk for IVH both on day 1 to 4 or at any point in time, as well as when they combine death or severe IVH, that this burden of hypoxia to the brain had significance even when it occurred early on in life. And then finally, I was at a conference in Belgium this year, and I saw a very interesting presentation from a group that was based out of Leuven. And they did this very nice study where they looked at almost 350 patients. On the left here are adults, and on the right here are pediatric patients. And this is data collected from multiple European centers. And they looked at the relationship of episodes of elevated intracranial pressure with a 6-month Glasgow outcome scale that is visualized in the colors here. And what I'd like you to note when we look at these graphs is that the insult duration is here on the y-axis in minutes, and on the x-axis is the insult intensity in millimeters of mercury. And from what we can see here, each color coded point, red to blue, defines a certain intracranial pressure intensity threshold. And I think what's nice about this is when we compare even a pediatric patient to an adult patient, we see that the kind of zero correlation line, which is this black line here, is shifted lower and to the left in the pediatric population. And I bring this up because I think when we look at our premature babies, I think the duration of cerebral desaturation or the degree of that desaturation may have implications, and potentially using autoregulation metrics and NIRS-based derived data could also highlight similar types of differences in our population as a way to risk stratify our patients. And so in conclusion, severe IVH is associated with poor neurodevelopment. Cerebral oximetry patterns differ in those patients who go on to develop IVH or who are developing IVH. I think monitoring can identify hemodynamic thresholds to optimize autoregulation and brain perfusion, and that both individual and cohort trends may help to identify at-risk infants. Thank you for your attention. As a tip in rounding in this COVID-19 era, I found that social distancing within the hospital on rounds is extremely difficult. So I had my kids make a prop that I could bring into the hospital, just make the point and joke with my colleagues. But I hope you're all well during this time, and I appreciate your time and attention. Thank you.
Chris, that was great. Thank you so much for summarizing a lot of that complex information. I think we'll open it up now to questions. Just make sure to unmute yourself, and to either Anup or Chris, let's open it up.
Can we ask each other questions, or is that, this is Anup?
Sure.
So I would say, Chris, I've been obviously following a lot of your work for a while, and I guess my big question is for the clinician, when including some of your own work, looking at sort of this opening, diastolic pressure, when could it be something where you could look at that at the bedside, or is it something that still needs time to be implemented, like heart rate variability and HERO or other things, or is there a way to integrate this real time?
Thanks, Anup, for that question. We are very close, and I think I would have been able to tell you that we were operational if we hadn't had this COVID infection interrupt a lot of the research that we're doing. But currently, we're streaming all of our vital sign data into a virtual cloud. I'm sure, like many hospitals of members of this group. And we are in the final stages of being able to see that closing margin or that closing pressure on a patient and in real time at the bedside on a computer that's streaming all of this data. We're able to see all the NIRS data and everything else, as well as, you know, measures of autoregulation. So I'm interested to see how that will look once we're able to do that, and, you know, potentially understand a little more of how that Doppler and NIRS data is kind of interacting.
Okay, thanks.
I think along those lines, you know, until we can have that real-time measure of impaired autoregulation, people are always asking, well, how do we use the NIRS data? Is it like, you know, you have a high value before a baby bleeds, or is it a low value? And I don't think we can really say without, you know, integrating the rest of the streams of data. I don't know how other people in this group have been using NIRS in the context of IVH. For us, it's mostly been, okay, the NIRS value is super low, and if there's no other physiologic explanation, look for IVH. I'm just wondering if anyone else has, you know, anything to share about how their centers have been using NIRS.
Valerie, this is Zach. There's a really nice algorithm that's been published as a part of the SafeBoost trial, talking about potential different interventions you can take when your NIRS value gets out of range, and that's a really important point you bring up. When the value gets too high or too low, that's often the first thing people reach for, just like a pulse oximeter, is to turn the FiO2 up or down on the ventilator to try to manipulate that. But if you follow one of those standardized algorithms, there's a lot of other stuff, looking at the CO2 volume status and so on. That'll be really important to make sure we're using the right treatment to target the out of range NIRS value.
Hi, Valerie. Can you
Yes.
hear me? This is Rhee. And I really want to thank you for organizing this activity. I mean, this program, very helpful, and thank you for the speakers. We have done this quite for some time. And when you see the publication, you know, when you have certain numbers, you see a fairly good correlation. But if you look at in the details, there's quite a lot of overlapping and from the data. So in other words, for a given individual baby, the cutoff is a little more difficult. That's one thing I want to sort of let the group share this experience. The second thing is the higher number or lower number of the saturation. I think also not only it's have a lot to do with the timing, because here we still do not, we need to sort it out whether this higher or lower number is a cause or is the consequence of a bleeding. And I think that's probably have a lot to do with the timing. And if you see it in the delivery room, it probably means something. But if you see it around the time of a bleeding or even after bleeding, it means something different. I'm a little bit hesitant to say we should, based on what we know now, to say adjusting whether this baby should have more oxygen or less oxygen. But definitely, I think we need a study and to see. That's my kind of my thoughts.
Great points, Dong-Lee. One question I had for Anup, how often, you know, just kind of in your experience, is there a discrepancy in the DEL room between the cerebral saturation and your SpO2? Like, you know, how often do you see like a really big change between the two numbers that you wouldn't necessarily expect?
You know, again, to be totally honest, we're not using it. It's been only for research, and you know, we've used it in a number of, not just this trial, but our other ones. And when we've only gone back and looked at the data, because we intentionally kept these blinded because we weren't looking at that point to intervene. But the discrepancy actually, to me, was quite remarkable at how much higher, and the stats are higher, as you can see from those curves, right? in terms of your cutoffs, but than your NIRS. But oftentimes the SATs would come up quite nicely, and it would take a very long time for those NIRS to come down, particularly in those really sick babies. So, I don't know if the answer is just oxygen. Obviously, we're also interested in things like, the right amount of blood volume, et cetera, that these babies have, or are there other things to do, or, where you could get these babies on the cord longer, or other things to improve their NIRS before. But I think there is a discrepancy, and I think the question is the right intervention. And if this COSGOD trial shows that going up on the oxygen earlier, I believe that's where some of these, or even like the cork data, trying to start higher quicker. I think a lot of people that have been looking at this oxygen question have felt like we've swung too far by being so nervous about going up on our oxygen that we're, seeing more data like low 5-minute SATs and other things where maybe we need to sort of get ahead of it a little bit faster.
Yeah, I totally agree. It's so interesting.
Hey, Anup, this is Zach. I had another question for you. I was wondering, you touched on this a little bit with the EEG electrodes more than the NIRS. I mean, we all have difficulty getting electrodes to stick to babies when they're first born. What strategies do you use to get the NIRS to stay on?
Well, and I don't know if I'm the right person. I think others are looking at this more, but the NIRS well we used was a very limited. Like I said, there was 1 grounded and 2 sensors. And that was literally cutting into the co-band, sticking on those leads. The leads are some of my earlier studies. We used this device called the ICON, which is a continuous cardiac output monitor. Some of you might have heard of it. Anyway, those leads are very tiny, which allows you to sort of put them, behind the ear and on the head, et cetera. But as far as keeping them staying on, just embedding them in that co-band that you wrap the baby in worked great. But we didn't see a difference, though, in our study, and that might have been due to the limited montage. And I think others that are looking at, these sort of embedded hats, mesh hats that just go right on the baby and they stay on, I think that might be the way to look at that if you're looking to move towards EEG as far as delivery room monitoring.
Looks like Mariana had a question that she can't unmute herself, but she was wondering how many people here are participating in Safe Boost 3? We are not, I think.
Jonathan, do you want to take that one?
Yeah, I was trying to find my own unmute button there. As of right now, there's a grant that's been submitted from the Cerebral Palsy Association Research Foundation. That's would cover about 8 centers in the U.S. Total. Outside of that grant, there are 2 or 3 centers that are gearing up to participate using their own funding mechanisms. If that larger grant was to come through, then that would probably open it up to about 10 centers altogether on the U.S. side. Unfortunately, we received recent word that their review process has been affected by the COVID infection as well, that they're pushing towards more essential studies right now, but they didn't formally rule us out. So if we're not out, we're still in. So we're kind of waiting on that one right now. That study is actively enrolling, and is at my most recent understanding is somewhere between 20 and 25% enrollment. But it's really been slowed down over the last 2 months or so with the ongoing COVID situation.
And Anup and Chris, if it's okay with you guys, we're going to make this link available so that people could refer back to your slides. You guys summarized so much information. It's wonderful.
Of course, no problem.
Yeah, that's great. I'm happy to participate in. This was really enjoyable.
Great. So I think we're just about the end of our hour. So if people have any feedback or are interested in different topics for the next webinar, please email us and let us know. Again, thank you all for participating. We know you're really busy, so stay safe, everyone.
Great. Thanks, Valerie.
Take care.
Thanks.
Bye-bye.
Thank you very much.
Thanks, everybody. Bye.